Hi, my name is James Forest-Lam. To those of you who watch my HTN1 talk, this is HTN2. Um, I I made a little glitch last time when I talked about blood pressure and cardiac output. Blood pressure is a product of cardiac output and the peripheral resistance. I will try to give you a little guidance from time to time to see what this program is, which direction we're going. And Again, I have been in the field of emergency medicine and internal medicine for quite a few years, and uh, have been certified and recertified in both emergency medicine and internal medicine for a total of 6 times. And I have been instructing ACLS uh, uh, and certified the combination at least 15 times. Um, uh, so uh, there should if I plan to put a talk about ACLS, one of these talks. My goal is to, in the next 2 years, put together the material that will help of you to be able to have the material ready for the post certification examination in both internal medicine and emergency medicine. Um, and I will try to put together the ACLS talk uh, because that applies to actually a greater audience, as you know. Many people, a lot more people take the ACLS certification than ABIM or the emergency board. Continuing the talk on hypertension, HTN2. So you have a patient in your office or your emergency department who has hypertension in the past. You've made a diagnosis of hypertension. Now, what do you do? You can check their lab first. Actually, as I mentioned before, most people who have hypertension at the time of diagnosis have no symptoms. You may not find anything except for the blood pressure being abnormal. Um, However, the boards love to associate the hard sounds of S4 with uh, hypertensive patients. S4 usually is they refer to a patient with hypertension. And S3, of course, is for congestive heart failure. Congestive heart failure, they say S3. Usually, they're trying to tell you the patient has congestive heart failure. Obviously, there isn't any physical finding that you look at and say, "Haha, the patient has hypertension." Um, the If you ever do an EKG, though, one of the more common findings that's pretty frequently associated with hypertension is, especially extreme hypertension, is the in T wave QRS incongruence, kind of like um, a T wave strain pattern. It's good to take a good history to see if a patient has a history of smoking, dyslipidemia, um, uh, the age, if someone's older age, obesity, um, and physical inactivity and family history. As far as laboratory studies to start, maybe before you start medication, would be creatinine, sodium, potassium, fasting glucose, UA with micro and ECG, EKG, some people call it, and a fasting lipid profile. As we discussed before, majority of the patients at time of diagnosis have essential hypertension. That means that they have no particular cause for their hypertension. They're a little bit less than 10% of the population have secondary hypertension, meaning that there is a cause of someone having um, uh, hy- causing hypertension, and of course those can be correctable, but at least you find a cause for it. Um, for example, renal artery stenosis that can be amenable to surgical intervention. Um, and also, if someone says to you, well, I love licorice, I eat licorice every single day, well, there may be your cause there because licorice, uh, licorice uh, inhibits the conversion of cortisol to cortisone. Sudden onset of hypertension in someone who's previously uh, normal tensive makes you think of secondary um, hypertension. Also, someone who develops hypertension very early, extreme hypertension very early on, less than 30 years, or develop hypertension after age 55. Those would make you think that maybe something, a secondary cause has occurred to make the blood pressure go up high. What are some of the substances that cause hypertension? Alcohol, amphetamine, over-the-counter medications like the congestions, diapil, NSAIDs, uh, s- cyclosporin, erythropoietin, ephedra, and as we mentioned before, licorice. What are some of the situations that cause people to have hypertension, pain, stresses, um, lack of sleep, sleep apnea, hypothyroidism, or hyperthyroidism? Uh, Chronic kidney disease because of the oversecretion of renin, which causes one to retain sodium. For some strange reason, the board loves the coarctation of the aorta as a secondary uh, cause of secondary hypertension. Um, the thing that they like to talk about is the rib notching that you find on the chest X-ray, and they might show you something like the some rib notching, and you're supposed to be able to figure out that's coarctation of the aorta. And what else you find? You find diminished pulse in the legs. So a delayed femoral pulse and a reduced blood pressure in the legs. The definitive diagnosis, however, most people will agree is a CT scan of the of the aorta, and definitive treatment is surgery. Little physiology of the of renin. Renin is secreted in response to any states that cause the body to think that you have low volume. So renin uh, converts angiotensin 1 to angiotensin 2. Uh, and when we take ARB and ACEI, ACE inhibitors, uh, we are really treating the to lower the function of the uh, angiotensin 2 receptor. Three major etiologies of renal artery stenosis uh, is any states that produce underperfusion of the kidney, um, uh, atherosclerosis of the renal artery, or in the especially the younger population, usually young female, um, fibro, fibromuscular dystrophy. It is thought that fibromuscular dystrophy in the female population, at least, is associated with uh, female hormones, and this occurs typically in a young woman, as opposed to atherosclerosis, which you find in the older men in general. So ACEI ACE inhibitors reduces the conversion of angiotensin 1 to angiotensin 2, whereas ARB, of course, stands for blocker of angiotensin 2. That is a reason why we don't use ACEI and ARB at the same time, because there's no use in using two medications that works on the angiotensin 2 receptor. The diagnosis of renal artery disease, renal artery stenosis, really is either CT scan or MRI. Ultrasound, even though there's no radiation, is very operator dependent, probably less sensitive. The captopril multi radionuclide studies probably is not very practical, because you have to stop the patient's captopril. That's not very practical. So we just finished talking about renal artery stenosis. There are other causes for secondary hypertension. Renal artery stenosis is only one of them. The other is pheochromocytoma, uh, which stem from the tumors originating adrenal medulla or sympathetic ganglia. And these tumors periodically release catecholamines, and the symptoms that one experiences are those of catecholamine spurts. Of the pheochromocytomas, somewhere about a third of them have a familial tendency. So apparently, the pheochromocytoma, majority of them are not familial form of the familial form, but of the familial form, which about a third of them, uh, they have uh, the following symptoms, findings: an association with MEN 2A and 2B. MEN stands for the other two things that the familial form associated with is this entity called the neurofibromatosis and von Hippel-Lindau disease, which is associated with renal angioma, cerebellar hemoblastoma, and um, renal cell CA. So, um, so again, von Hippel-Lindau disease is retinal angioma, cerebellar hemangioblastoma, and renal cell CA. So, so symptoms of pheochromocytoma, whether it's familial form or not, is associated with a symptom complex of headache, sweating, um, palpitation, pallor, white turns blanching, anxiety, weight loss, and the and orthostatic hypotension. A question related to pheochromocytoma I have seen at least two times uh, while taking the boards. The hypertension uh, associated with pheochromocytoma can be sporadic or sustained. If you suspect pheochromocytoma, you should screen with plasma-free melanephrines. And if you are still suspicious of that, then you confirm it with a 24-hour urine collection for catecholamines, VMA, and melanephrine. Catecholamines, VMA, and melanephrine. If the serum tests are still suggestive of pheochromocytoma, one should order an MRI to confirm the diagnosis and locate the tumors. Um, uh, of course, the definitive treatment is surgical removal of the pheochromocytoma. Preoperatively, however, the patient should receive phentolamine and phenoxybenzamine uh, to prevent any crisis from happening due to the release of these catecholamines. So preoperatively, give phentolamine or phenoxybenzamine.